Good morning. Are we all logged in? We might kick off. We've got an hour. My name is Susan Hayward. I'm a director at the National Mental Health Commission. Today I'm speaking from Ngunnawal country. I pay my respects to their elders, past, present and emerging. The purpose of today's webinar is to introduce the Mental Health Quality and Safety Guide, affectionately known as the SQUEG. You might have had a chance to look at it since we uploaded it online on the 24th of last month. Today, we are going to discuss the importance of the guide from a range of consumer and carer perspectives. Firstly, I'd like to introduce Ms. Kerry Hawkins, Commissioner at the National Mental Health Commission. Kerry is a Commissioner with the National Mental Health Commission and co-chaired the advisory committee for this project. She is also President of the Western Australian Association for Mental Health and holds several other board appointments. She co-authored the chapter Working with Families and Mental Health in the Australian edition of the Psychiatric and Mental Health Nursing Textbook. Kerry has previously worked as a director for the NDIA in the mental health team and is a graduate of Boston University's recovery class of 2013. Ms. Hawkins has acquired a solid understanding of the issues facing the mental health sector. This experience is complemented by her professional career in the private, education and public sectors, including working as a project management consultant at KPMG, a high school teacher and a strategic advisor for the National Native Title Tribunal. She has previously worked as a senior program manager for the National Disability Insurance Scheme, the WA Mental Health Commission, and as a carer consultant for the North Metro Adult Health Service. Her other board appointments include Vice President of Helping Minds and WA Director for Emerging Minds. I'd like to welcome Kerry to give some opening remarks.
Thanks, Susan, and a very, very warm welcome to everybody attending today. I would also like to pay my respects to the First Nations people around the country. I'm coming from the Whadjuk Noongar country and pay my respects to their elders, past, present and emerging. I'd also like to acknowledge the many attendees here today with lived experience and acknowledge that this can be a topic that can be extremely distressing and traumatising. So I would certainly say to people, look after yourselves. We're aware of it. This is exactly the topic that we've been wrestling with for the past 18 months or so. I'd also like to acknowledge the giants of the shoulders on which we stand, who have worked tirelessly in this space to push us forward and get us to the point where today there are so many people with lived experience attending, and certainly so many people with lived experience who are part of the advisory committee. And I'd also like to acknowledge the people from Western Australia, particularly I can see in the attendee list there's quite a few there, so I'm delighted and applaud your efforts at getting up early and welcome you all. Okay, in terms of the guide, we've tried to really position this quite carefully. So it's obviously another welcome addition to Australia's investment in the consumer and carer engagement space. And this is something that certainly you will all be aware of in terms of the Productivity Commission and the recent Royal Commission in Victoria. So we know that in terms of designing and delivering mental health services, this is now a legitimate space for people with lived experience. So this particular guide is a priority action under the 5th plan, Action 21.3. I think it was carved into my memory pretty early on. And we've been working for over 18 months now to deliver this. The role of consumers and carers in this space, both design, delivery and evaluation of mental health services and resources available to people, is absolutely critical. There must be dynamic and viable partnerships between service users, service providers and service leaders. We've called it the SQUEG, so apologies for that, an acronym. It sits nicely amongst all of the other acronyms that we've come to know and love. Is a practical tool aimed at empowering mental health consumers and carers, health service leaders and service providers to engage in meaningful partnerships to improve the safety and the quality of mental health services. And certainly throughout the project, we were very aware of understanding what safety meant to people with lived experience. We note that this is a production that already sits amongst a plethora of other engagement frameworks and guidelines that are out there. So the National Mental Health Commission, under the late Jackie Crow, led the way in terms of providing significant leadership in this space in the sitting beside me, not above me, various other engagement frameworks. And we're also very aware of amazing work that's been done by Flick Gray and Kath Roper, the principles, putting principles into practice, as well as all of the state jurisdictions. So we were very, very conscious of finding something and finding a niche that would add to the tremendous range of products that are out there. And the aim is to support and create positive change. So this is a change document. It's not intended to sit on the shelf. One of the most formative conversations we had very early on was that we didn't want to see this become yet another document that is not used, that is untethered from practice. So for health service leaders, we hope that this guide provides information and supports you in supporting diversity. We had a very conscious diversity lens over this publication, and in creating a safe environment for people to participate. And also looking at the role of leaders in creating capacity within services to make it easier for everybody to do this work together. I would like to thank all of those who made a contribution to the development of this important document, in particular the advisory committee members. So I'm delighted to see Eileen is here. And we had some other people from the National Safety and Quality Commission, various other people with a strong emphasis on lived experience expertise in driving this. We also had significant support from the University of South Australia research team, so Nick Proctor, Dr. Mark Loughead. So there was a team there that also included people with lived experience. So following on from that, I'd like to introduce now some of our panellists who were part of that advisory committee. And I'll hand it back over to you, Susan, to go through the introductions. Thank you.
Thank you, Kerry. So we have 3 guests on our panel. Firstly, I'd like to introduce Hayley Solich. Hayley is a carer and co-chair of the National Mental Health Consumer and Carer Forum. Hayley has 5 family members who have or are experiencing mental health challenges that she supports. Hayley also works as a carer peer engagement officer in Western Australia, where she is currently delivering carer engagement training in hospitals and community services, as well as serving the community at a systemic advocate local, state and national levels. Hayley is passionate about uplifting the voices of others, of influencing positive mental health reform and the development of the lived experience, both paid and unpaid. Secondly, I'd like to introduce Terry Warner. Terry's a consumer representative from Mental Health Australia. Terry has worked in mental health advocacy in both paid and voluntary roles for a combined total of 13 years. She's known in the ACT as MIE ACT Volunteer Educator and Consumer Representative for both the ACT Mental Health Consumer Network and the Healthcare Consumers Association of Australia, of the ACT, and nationally as the SANE Australia Peer Ambassador and member of the Mental Health Australia National Register of Consumer Representatives. Terry was the chair of the ACT Mental Health Consumer Network from 2015 to 2019 and has co-authored several articles published in international journals on the topic of lived experience leadership and the involvement of experts by experience in health and social care education. During Mental Health Month last year, she was awarded the 2020 ACT Leadership Through Lived Experience Award. She has an advanced master's degree in culture, health and medicine, and is currently working towards a PhD at the ANU Medical School. And last but not least is Darren Jiggins, TAS Director, Lived Experience Australia and Director of LEA Training Program. In the 90s, Darren met his first peer worker in a self-help group for people living with OCD in WA. Over the years, he engaged with Lived Experience Australia, LEA, and a private hospital to represent consumers on their Consumer and Carer Advisory Committee. A significant part of this role was to work on safety and quality initiatives and in accreditation. This resulted in him joining the working group to assist the National Mental Health Commission in the development of the Stakeholder Communication Kit for improved engagement for all. As a director of Lived Experience Australia, Darren is dedicated to bringing systemic changes in Tasmania and in the design and delivery of LEA training for consumers and carers and staff and engagement programs. Kerry, I'll throw to you for a little bit of a Q&A, and then we can have some open discussion and some questions from the floor following that.
Thanks, Susan. So certainly we'll open off with some questions that we've thought about before for the panelists, but I'd also invite you all now to start thinking about some questions that you might have about the guide if you've had a chance to have a look at it now. And so certainly pop them into the chat box. So Terry, I'm going to start with you. And certainly this is some of the questions that we asked ourselves as part of the project. So my first question for you is, if thinking back, how did you first become involved? It's actually quite a step to go from being someone who receives services to being an active participant in quality and governance systems, which is very much the focus of this guide. We're really focusing on governance. So can you think back to what was your experience when you first became involved?
Well, having accessed mental health services for over 20 years and having been a healthcare consumer my entire life, I had seen a lot of things that needed to be changed and had a lot of experiences that I wish had happened differently. And I wanted to change things for myself and for other people. And I actually started out in community education, doing stigma reduction, lived experience storytelling, that sort of thing, talking about myself a lot and my own experiences. But then I realized, and it's a little bit embarrassing to admit this, but I'm a good policy person. I'm actually good at understanding processes, models, and procedures and why they are the way they are, especially in health. And I'm good at looking at them through a lived experience lens and bringing that perspective in ways that health services can understand and engage with. So I did some consumer representation training with my local Consumer Peak, and I later went on to become the chair of that Consumer Peak. And I started sitting on committees in my mental health service and also in my health service more broadly. And now I speak locally and nationally on a lot of issues that face mental health consumers. And I speak from that lived experience perspective.
So important and so powerful. Thank you. And I think you've identified, like many people, you've come from a position of going into services for help and possibly not finding or having the experiences that gave you that help. And I happen to be talking with the chief here in Western Australia of the Health and Disability Services Complaints Office, and the major theme that came out even right now this year was that people came out feeling worse. And that certainly can be what activates people to become involved in this space and to contribute positively, as you've said, through that experiential lens. Can you go back to when that first time, was it, you mentioned through education, and the first time you kind of stepped into a space of being the expert? How was that for you?
Oh boy. Well, because of my background, my first committee as a consumer rep wasn't my first ever committee, but I remember walking in and being really aware of the difference in power between me as the person coming in from the lived experience perspective and the executive director of this and the operational manager of that, as compared to what the relationship would be if I was one of their staff or if I was another member of the executive. And I walked in and sort of went, why am I here? What have I got to say? Are they even going to listen to me? Do I know what I'm doing? So it was overwhelming and intimidating, even for someone who'd actually worked as a staff member in those types of environments before, because of the change in the power dynamic and the way you're seen when you come in from a lived experience perspective.
Oh my gosh, I think for people listening to that was so powerful and probably resonated so strongly. Certainly in mental health, that's why we have co-production, because it's an unsafe environment for people to be into. And we spent some time talking about from the perspective of this guide, one of the most important things in safety and quality committees is having people feel safe on the committees themselves, let alone in services. So you've touched on some really, really important things. So in terms of the guide then, because we did talk about this, how do you think the guide could possibly help address some of those power imbalances that feel unsafe to people?
Look, a former head of a tax agency once said that you actually need people to pretend to be tax forms so you can understand how they move through the system, as opposed to how the designers envisioned them or how the people who work within the system think they do. And that's actually one of the functions of consumer participation in healthcare, especially at the organizational and governance levels. Unlike in tax systems, though, mental health consumers don't have to pretend to be people. We move through these systems in ways that weren't anticipated by designers because our lives are more complex than they could account for, and in ways that the people who work within them don't understand. And sometimes, especially so in the case of mental health, ways that people who work within them will never experience for themselves. And we're both helped and harmed by the way that these systems operate and how they interact with us. So we often know what we want to change and how we want things to be different, but not always how to get there from the way things are, because bureaucracies can seem impenetrable and health services are unfailingly bureaucratic. That's why resources like the guide are so helpful, because quality and safety work in mental health, while it embraces and to an extent operationalizes concepts like person-centered care and recovery-oriented and trauma-informed practice, it is in essence a system-centered mechanism that is itself operationalized by people who work within the system. So sometimes for consumers, the really important question is, what do I need to know about how the system works for my advocacy to be effective? And the guide is designed to help you navigate that.
Thanks, Terry. That was so eloquently put. I think that you've described so powerfully the gap, the scale of the transformation that's required between meeting the complexity in people's lives and the system that, as you say, was designed by service providers, not by service users. And I remember Simon Strafagi, a psychiatrist in Melbourne, wrote quite powerfully in The Age several years ago saying, the system's not broken, it was designed this way. And so every other sector, of course, designs services around the needs of people, whereas often we're shoved into, the very, very limited understanding of mental health that the health system provides. It's very context blind, and for all of us, we know that in fact our lives are about our contexts. So we have to find ways to translate and bridge, and as you say, that's what the guide is. Thanks so much. We'll certainly come back to you to explore some more of those amazing ideas you've just touched on. Hayley, I want to move to you now, so thank you. And again, I'm kind of getting people to think about from your memory how you first became involved. What was the moment for you, particularly in the quality improvement and the governance systems?
Okay, so my first introduction was I got a job within mental health services as a consultant from a lived experience perspective. And so I had a big step to get over in terms of the language. Was a big barrier to start off with, understanding acronyms and other things. So I had to quickly find within the system people who would be able to support me, because I am an external processor. So it comes from conversations more than from reading for me. So I needed to find those people that I could surround my life with. So the most valuable thing for me was finding a mentor. And I had a great mentor in WA through Lorraine Powell, who took me under her wing and helped me get through those first years. And then there were others added, like Eileen McDonald and others from the forum. And so they helped me to navigate the space. Had there been a resource like the guide, that process probably would have been a lot easier for me, because it's got so many tips and things of value in the guide that cover off on some of those things that I just didn't know. It's like a new language, mental health services. I'd worked in the public service, so I had a sense of the public service as an organism, but I didn't have this organism called mental health and the way it speaks about things and how it views people. And so I had to gain that knowledge and experience. And so having a mentor was really, really helpful to me. And the other thing was developing relationships with the lead people that were in meetings. So with the chairperson or liaison person or someone who was warm or empathetic on the different committees. So it was finding people who would be able to help translate information for me, and also navigate some of the time. So when I started on the national, in the national advocacy work, the time zones and where meetings were, etc., were sometimes a bit tricky. So having other people help me navigate those things was really helpful, and also pointing towards relevant documentation, because you don't know what you don't know until you know it. So the other two things that helped me were doing some solid preparation for meetings. So coming well prepared was important to bring something of value to the conversation. And so that required a step before the meeting to be across what the information was that was going to be talked about, and also talking to people outside of that particular space in terms of the people that what we were talking about was going to affect. So it's going and talking with other carers in support groups so that I could bring forward their voices to the conversation, not just come from my own perspective. So a lot of those things are not things you write in a book, but the guide, from my perspective, when we had the conversation in putting the guide together, I really valued the opportunity that was given to us to talk about what the barriers were with the consultant, so that some of the things that we don't know about can be put into the guide as, hey, you might want to consider doing this, you know, in terms of speaking from that broader perspective. For example, I didn't learn that until a little bit down in the meeting process of what was required or expected of me. So I think the guide is really helpful in letting us know what we can expect of others, and B, letting them know what a consumer or carer might expect from them if they're running a meeting. So for me, that was the big takeaway from the guide, was that communication of what to expect, and also what's expected of you.
Thanks, Hayley. And as you're talking, I'm thinking of almost like a Lonely Planet guide for travellers, and we're kind of traversing foreign lands for each other, and we need our bilingual dictionaries to go with it. And certainly this guide does go some way towards that. Can you think back to your first meeting and how that felt, walking in as a person with lived experience?
I try not to think about my first meeting, because I was in a difficult situation, and I was crucified by the people in that meeting, and they weren't service people that crucified me. It was my peers, unfortunately. So it was a really difficult meeting, and I think that comes back to those expectations, and services can do a lot in preparing the ground to bring in members who are coming from a lived experience. It's all around the preparation of the service for a role. So I was in a lived experience role that had not been well communicated, wasn't co-designed with the people that it was going to be working with. And that was a real problem for those people. They saw it as someone being lumped on them, you know, enforced on them, rather than it coming from within their own group. So I think that I guess my takeaway from that was co-design is really important when you want to do work in the lived experience space, and it's really important to respect the viewpoint of the people that are going to be working with whoever it is that you're putting in there. They should have some, you know, some skin in the game, is what I think, in that process, so that the change is more easily accepted within the group. But certainly when I went into my first safety and quality leadership meeting, which was a state level meeting, everyone's talking statistics around me, and some of those things I hadn't had exposure to. And once again, feeling like a foreigner in a new country that's speaking a whole new language, it can be quite daunting. But I guess my advice to other lived experience people is just hang in there. The ground does settle, and sometimes it takes 6 months or 9 months for you to get the landscape that you're working within, but eventually it does come around. And the more that you're exposed to things, the easier it does become to understand what's happening around you, and also to not be afraid of asking what you think might be dumb questions, because guaranteed there'll be others sitting in the room that wish they'd asked the same question but were too afraid to speak up about it. So there's no such thing as a dumb question in any meeting, and sometimes the language is quite foreign.
Thanks, Hayley. Yeah, that's so true. If you think about the guide, and you've discussed there some of the significant emotional barriers to being involved, how do you think the guide, what are some of the key features of the guide that can kind of help people get over that first hurdle, or the first 6 months of feeling unsettled, and stay engaged? You know, this is one of the key features we know of deep engagement, is that people stay engaged and relationships are developed. So what are some of the things in the guide for you, do you think, that can do that?
Okay, there's a section in the guide that is around how, so I'm just trying to find the title of it. Just give me 30 seconds to find the title of the actual section. Enabling diverse participation section is really cool, because it gives you a better understanding of different cultural bases, but also working together. That section on how to work together was really powerful for me. It broke down some of those things that are around those expectations parts, and I felt like the inclusion of the lived experience voice in there, because there's little quotes right throughout the guide that are from the lived experience perspective, just made it go, oh yeah, this is for me. I belong here in terms of the guide. I felt like there's the voice of consumers and carers in the guide, and that was really helpful to me. And I think it's also around, not only is it good for me as a consumer and carer to come back to the guide and go, well, hey, I don't know what I should do in this circumstance, and perhaps it's covered, but it's also good to, point some people you're working with to the guide to say, hey, you might want to have a just read of this section. I think you might find it of interest or helpful in what we're doing. So I think from my perspective, those how to work together in a positive way was a really good section to keep the longevity going in the relationships.
Thanks, Hayley. Yeah, I think that's so important. Having some points of recognition within a document can make you feel as though you belong and that you're home. And certainly that's not an experience one often has when you're looking at the meeting documents going into some of these committees. Thank you. Darren, can I just turn to you now, because I wanted just to touch briefly on the importance of the safety and quality engagement guidelines within the context of the 5th plan and its strategic importance in terms of all of those projects that are being done.
Yes. Can you hear me, Kerry? Yes, great. Thank you. I'm just reflecting there on how good it was for us to see that this was one of the recommendations from the 5th plan. But reflecting back to Hayley's comments, it's just terribly hard. And thanks for sharing those experiences, Hayley, because they're terribly hard experiences. And I think that's, a lot of us have been advocating that we need training, and we need for staff and for us too, to help us with our skills about everything that's in this current document. So thanks, Hayley, for that. It was really and I think the majority of us have had that experience. So the fact that our experiences and through advocacy led to the 5th plan being this was one of for us the key parts of that plan. And that for me that was an amazing thing that we managed to get on the federal level, to get an understanding that we really needed this to be a document that does deliver the strategic goals that all hospitals and through all the processes and can be used right down to the coalface, and that's what I'm hoping will come out of the document. So, and the other thing too, that I was very pleased with the way, because I was on the committee that helped guide the guide. I never felt pressure from government. I don't think any of us felt pressure that others were, that we were there as a token to that our voices weren't being heard. So I think for me, hand on heart, others may have had a different experience, but I think for most of us, this really was, a consumer carer drafted document. So.
Absolutely. I think the voice comes through very strongly. So that's step 1. Step 2 is having the voice heard and acted upon. So that's from after this webinar. That's all of our mission here. So Darren, the other thing I'm interested in, because the intent of this guide, obviously because it's a 5th plan project, was obviously focused around public mental health services, but we were hopeful that this could then be translated out into other sectors, the NGO sector, even outside of mental health. But in particular, from your perspective, and we certainly had a representative from the Private Mental Health Network on this committee, can you talk about how you think it might be implemented within, or the potential within, the private mental health system?
Yeah, and I think it's quite often, because I'm director in Lived Experience Australia, and our particular focus is giving feedback and working with private hospitals. Because there's quite a lot of them, and they're quite big, and the consumers and carers that use those services, they're not perfect services. There are no perfect services, and so it's just as important for us to gain a voice within those services. And I suppose that, because it's so, and I'm sad to hear that Hayley's story, but I think I just got lucky to have started off in a private hospital, and my experience was really quite good. And I think the fact that, it's really up to us now to think about how broadly this can be used, because, engaging consumers and carers in the mental health space, as you said, we can use this in all parts, the NGO space, like you said, and it's free. It's free. We can go to these staff who the staff that I've always spoken with, who are most keen on the ground to be engaging with consumers and carers. They're very keen, but they're also very concerned about, they don't want the experience that Hayley had, because I think, in the 20 years that, that we've been doing this, I think things have changed, and that it's probably, they are more experienced in, working professionally with consumers and carers. So I think this is, I think we really need to grab this guide and not be timid about going out there to promote it, really, because now is the time where we go out there to, like you said, in as many places that we can, to introduce this document, I think is important.
Absolutely. And you're right, it's so much the right time. In terms of, as you say, going out there and introducing it and not being timid, can you think of any practical examples where you would grab the guide or the digital version or a tip sheet and go to somebody somewhere in your system and say, right, this is what we want used? Yes.
I see that there's a question there. Our second question is, what is the implementation process around the guide? So the National Mental Health Commission will be using all of its tools and strategies to get the guides out to the states and territories and all jurisdictions. But I really do believe that, when I was tapped on the shoulder about a week ago, and they said, hey, can you be on the panel to talk about SQEG? And I love SQEG. And as we were speaking, the communications people were saying, so what's the most important things that you want to say? And I was saying, it's implementation. It's actually, how do we, because to a certain extent, there will be a top-down process that it will be sent out through the departments. But I think for consumers and carers, this is an opportunity for us. And the other day, when we were talking about this, and they were saying, so how would we implement it? It's as simple as picking up a pen. It really is. And I would like all panel members, actually, have you all got a pen? One pen? Two? No, that's okay. You can try a few pens. I think the power in talking to the communications people, when I was speaking to them, and I thought of two things straight away of how I can implement this or help implement this. So I picked up my pen and I wrote down 3 words. I promise to. So if you could write down, I promise to, because the people that we have, the 25 people we have here, we are all key people to get this document out from the grassroots to introduce it. So I would like to encourage everyone actually today to write down in their diary, I promise to do the next thing. How can we, as individuals, as leaders, every person in this group, I can guarantee you're all leaders in consumer care movements, and it's up to us. Now, what I wrote down on a few days ago, I wrote down, I promise to take this document to, it's very conveniently on the website, and as a Lived Experience Australia, I get to travel around Tasmania to the 5 hospitals. So I promise you all, I promise to the whole community that at those 5 meetings, I will do my very best job to introduce the guide at the 5 hospital meetings. So that's my commitment to you all. And the second commitment that I have put in place, actually, it's on the agenda of the next 2 meetings, the next meeting of Lived Experience Australia in Tasmania, but also the consumer organisation Flourish. I've put an agenda item on there to do exactly this, to get every single person at that meeting. This document is so important that we get this document off the shelves and actually into the people's minds who really need this. These are the staff that they might coordinate the Consumer and Carer Advisory Committee in a hospital, let's say. So in those hospital environments, I'm going to make 5 appointments to go and meet those people and to tell them about this fabulous new document that will help them in every step of the way. And I can tell you, if they are engaged at all, this will help them out as much as it will help us out. And like the document says, it's a part of working with services. So that's my promise to you, and I hope that we can all do that same thing, that the implementation process is so important, and it needs to be very much from the grassroots. We need to take the reins with implementation. Thank you for the question. Question number 2.
That was a great question. Thanks.
And maybe if people can put in there in the chat, what is your promise?
Yeah,
what
that's a great idea.
People, what are you going to promise to do with this guide? It doesn't have to be, maybe some people might go to the minister. That's definitely possible. Maybe others might go to people who they know that can influence hospitals. So I'd be very interested to see people's promises in the chat line. Thank you.
Great idea. Thanks, Darren. Thanks very much. And thank you to all of you panelists for your honesty and bravery in talking about experiences in this space. And it's certainly been a key feature of the process for the production of the guide. We have to be honest. Okay, so I'm going to take it back now to Susan to go through. I notice we've got a question in the chat and also in the Q&A. Darren has certainly well addressed the question around implementation, and we may well co-produce some other versions of how we go about that. So thank you. Susan, I'll take it back to you now for the questions.
Thank you, Kerry. That was awesome. Thank you for that discussion. It was fabulous. I'll start with a question from Sharon Lawn. I'm interested in the panel's thoughts on how we overcome the problem of consumers and carers being labelled negatively if they experience poor engagement, then assert their needs, etc. Who would like to respond to that?
And Sharon, that is such a wonderful question that sits across all movements of oppression, that the problem is located often with the people who are the victims in a sort of angry black man sense. And most family members and consumers will have experienced it as sometimes a very, very pertinent question. Terry, I might just, we did have a conversation in the warm-up room before the panel about how we were going to handle some questions around. But I think you've certainly done some thinking about this based on your first conversation around some of the questions of participation. And so I'm wondering, just as a sort of initial thought to kick off the conversation as such an important conversation around how we overcome this positioning of the problem sitting with people who have negative experiences, so that we don't have often people who are invited onto committees are the ones that don't challenge. And so we need to create spaces for all experiences. So certainly I'm interested to hear what you have to say on this topic.
Yeah, it's a fantastic question because it is a really big problem. It is very true that health services prefer critical friends over people who have had negative experiences and have been harmed by them and want that sort of really deep systemic change. And one of the things that I've had to learn over time is that when you're working in safety and quality type spaces, often it is about how you frame the problem, because they want to frame you as the problem, you and your grievance and the point in your recovery that you're at, because it's easier and more comfortable for them to say, well, that's actually not a systemic issue. We're very sorry that happened to you, but we don't need to do anything. So it's about framing the problem as something that is systemic and something that is achievable, and in a context of quality and safety and things like the National Safety and Quality in Healthcare Standards, tying it back to a standard and their next accreditation audit is a really, really neat trick. If you can do it, you can actually say, look, this directly it actually directly relates to standard 2 and standard 5 in these ways. And if you could come up with something that would fix this problem, then you'd have some really good evidence against those. So knowledge is power, knowing how to frame things so that health services actually recognize that they are the problem rather than you being a person who has a problem. Those are two things that I've found have really, really started to change things.
Brilliant. I knew you'd have done some thinking about this. Thank you for that. Absolutely. I think in some ways it's often about understanding the tools of rhetoric and the tools of narrative shaping and understanding deflection and denial and so on. So certainly building capacity with people with lived experience and using the authoritative structures that we have in place, like standards, to reframe and redirect the source of the problem. Anyone else on the panel? Do you want to jump in with some thoughts about this question? Hayley?
Yeah, it's interesting. I had a situation recently where I had to actually make an informal complaint about a service. And then I actually had to go out and deliver training to that service just this week, in fact. And so for me, in structuring that complaint process, I went with the mindset of solution, and to help them see how the solution could be arrived at. I think that often what happens in services is they get the problem, but they don't get the solution or how it could be fixed. And they don't get it from the perspective of, you know, this is the systemic issue. Often what happens is the person is talking about what's happened to them and how it's impacted them, but they're not actually sort of looking at it from that bigger picture. And so when I put in that particular complaint, I was talking about the issue. It was relating to COVID and carers being cut out at COVID time, which just happened because of the way going to phone calls rather than actual face-to-face meetings. So it was interesting to take that back into the service through the engagement training, and it came up in one of the sessions. And so I was faced with the awkwardness of knowing I'd made a complaint, that potentially one of the people that I had been a key player in that complaint process was sitting in the room. It was quite an awkward moment for me, but I knew that I had gone with a solutions focus. Had I just gone with a complaint that said, you know, you're not doing it right and I'm having a negative experience, I think that would have been a really very difficult position for me to be back in and have to talk to. So I think I'm agreeing with what Terry said. It's very much around how you frame what's happening as your experience so that you are seen as wanting to have a positive resolution that's going to be win-win for everybody. And I think that's a real key to influencing the change that you actually want to see. Nobody likes to just be criticised. But if we are given critical feedback with potential of how we can change, then we're more open to receive that critical feedback.
Thanks, Hayley. And I think for me, the other part of this, of course, is that this is not a problem that should sit with consumers and carers. This is a problem for services to attend to. So the onus should never just be on an individual in the system. We have to build structures and capabilities within services through processes like co-design, just to make sure that there is onus on all sides to address these problems. So Sharon, I hope, I'm judging by your comment there, saying thank you to Hayley that we've answered the question. We might move on to the next one.
Darren, this one is for you. In line with your discussion of services, the first line, ED, is so lacking. It really starts the process in a very punitive manner, restrictive practices. How do you see this guide assisting ED facilities?
Yeah, it's a very challenging space. The panel will help me out. Who the person who is doing the research for us, her name, and she's an author on the peer workforce.
Are you talking about Louise Byrne for the lived experience guidelines?
Byrne, yes. Thank you for that. I've drawn a blank there for a while. So I was reading a piece by Louise about the peer workforce in ED, and I thought it was when I was reading the question, that's where my first thought went to. I can't quote directly, but from memory, Louise was saying that ED is the most difficult, the most rigid structure, and the most medicalized part of all of the systems. It is a very much a very rigid, difficult place to go to find, care and empathy and a recovery focused. And absolutely, I agree that when you're looking at probably half of the consumers that go to ED are going there against their will. They don't want to go there. So therefore they're not consumers, they're patients, and we have a lot of challenges there. So there's two things. I think we need to, we do need to take this guide to those services. Absolutely. We do need, because those services won't disappear. And also, I think your comment's really good, because even for people who are not there with psychosocial disability or mental illness labels, I just think for every person who goes to ED, the staff need to be thinking about the distress experience for everyone who goes there. I think and so I think it will take a lot of time though in ED, because it is so rigid and so medical. I think the ray of sunshine that I'm seeing around the nation is the launching of the community centres, the 8 community hubs, and the states are doing similar things, where hopefully people like myself, I won't need to go which is my experience, that I do need to find a safe place at times in my life, and ED is the only place that I have that is safe for me. But it is a terrible place to go to, and we need to do a lot of work there. But hopefully in the near future, I'll be able to go to somewhere in the community to get supports there. But we need to take this guide, I think, into every place. Yeah. And I would like to give a big thank you to Sarah, who's made her promise. Jen, thank you. We've seen her promise. And Sharon has her promise up there. Thank you.
Thanks, Darren. Yeah, I'm keeping an eye on them pop up as they come through as well. Thank you. And I notice also that Eileen has mentioned that this guide will be invaluable to give to members of the ED advisory groups, and certainly with the advent of peer workers and the peer workforce within safe haven cafes and so on, it would be essential for them to have it as well. So slowly. Thank you. Okay, next question.
Next question. I am used to seeing implementation checklists with supporting guides. Will one accompany this guide to assist providers, etc.?
That's a great question, and we haven't gone through the process yet of how we're going to further tweak this so that it does become implementable. We've certainly had discussions as part of the committee. We thought actually it's a great question, that implementation is the most important part about this guide. And so I can see, Darren, you've got your hand up, but we certainly have had some conversations about how to make this actionable.
Yes, and we did. And thanks for the question, Carly. I think when I think about my time on the Consumer Carer Advisory Committee, I think for myself, I'm always really, I think consumers on those committee and carers will become more engaged when they make their hospital specific or service-specific checklist to go with the guide. I think everyone says that you shouldn't reinvent the wheel, but I think in inventing your own checklist for your own service, there's a lot to be gained from that. And that's where I think that is where consumers and carers can be involved and be engaged in finding out from other services what are the best checklists out there? How can we tailor this checklist to our service? I think if we had have come out with a blanket, you must do this checklist, and we may come out with that may come out, but it will just be a guide for people to, and that can be changed for the individual service. There's a lot to be learnt from designing the wheel again, I think, and finding out what other wheels, how they've been designed. So I would encourage you all to do that within wherever you're involved.
Yeah, thanks, Darren. That's a really, really valuable point. There are so many checklists out there already that are not used. And so the process of co-designing a local one probably increases the chances that will actually be taken up and certainly be more relevant because it's tailored. Thanks for the question, Carly.
Another question from Carly is, may I ask whether any of the panel members have had to challenge stigma about capacity and knowledge, please?
I'm seeing Terry nod eagerly on this one. She recognises a lot of this question.
100%, and not just when I was starting out. I remember in the early days being on a selection panel for a lived experience member of a strategic advisory committee, and it was chief psychiatrist level type people, and they didn't know me, and I was very new to things. And the very first applicant we had, no matter which way you looked at it, didn't meet the selection criteria. And they deliberately all turned to me and said, Terry, what do you think? And there was the sharp intake of breath, and you could almost feel the spotlight on me. And I'm like, this is a test. Because they could have asked anyone else in the room what they thought, because we all know that this person is not suitable, but they deliberately put it on me. And they might deny that, but it was one of those microaggressions where you kind of go, I know that you don't think that I, as just a person with lived experience, am up to this kind of task. And even very recently, I was on a panel where it wasn't actually a health service, it wasn't a mental health service, it wasn't even a health service. So props to them for wanting someone to speak from a lived experience on mental health. But I walked in and the attitude was, oh, Terry, it's so inspiring for you to be here and come and talk to us. And we're so incredibly grateful. And have you ever done anything like this before? And part of me was going, sweetie, Google me. Because, but that is the thing is people are not expecting me. I often don't know what they are. Actually, I do know what they are expecting. They're expecting someone who doesn't have the capacity or the knowledge to engage. And I've actually now got to the point where I will take advantage of that. And it's quite funny when people who have seen me speak before, and an audience of people who've never seen me speak, and I start talking randomly about tax forms or about my home renovation or about a bad picture of my dog, because everyone who is looking at me as the consumer who's there to talk about the consumer perspective is going, oh God, where is she going with this? But the people who've seen me speak before are going, we can't wait to see where she takes this, because it's going to be mind blown for all of the other people in the audience. But it does suck that I can do that, because I can't just walk in there and be recognized as an expert in my own right. I'm still having to earn it every time with every new person who has that attitude about especially consumers and especially mental health consumers. So thank you for the question, because yes, it is still a thing that we need to talk about and that we need to address.
Yes, absolutely. You just remind me of that movie. We need to talk about Kevin. We do. We need to talk about stigma. We need to call it out. And I'm delighted that the National Mental Health Commission is going to be undertaking a stigma project this year that moves beyond just the old-fashioned 90s understandings of mental health awareness. It's going to really attack and address it from a lived experience perspective. It's such a critical feature of this conversation. Absolutely. Hayley.
And I 100% get where you're coming from, Terry. And there are so many stereotypes of what a consumer is. And the beautiful thing is that not many people fit any of those. There's such a vast consumer population, just like there is a vast population. I just also wanted to make the point that sometimes carers also get the same kind of stigma, especially in services. There's a stereotyping of carers that they are complainers and there to make trouble, etc., etc. So I think it is a shared problem that we have, that we can, through our eloquence and through the way that we work to influence services, being solutions focused, etc. I think that that's something we can shift, and we will shift over time, because we're very determined to be seen and taken seriously, I guess, in the process of bringing that mental health reform.
Thanks, Hayley. And you've reminded me yet again that co-production is not a moment in time transaction, it's based over time. And I think you've both spoken to the fact that stigma can be addressed and called out over time as you develop relationships with your committee members and so on. And as Terry said, they're going to expect their mind to be blown away by your expertise. It's a delightful experience. We've probably got time for one more question. Do we have any more, Susan?
No, we don't have any more questions. We've got 3 minutes left. Would anyone on the panel like to make some sort of observational closing remarks?
Yeah, just on the last point there, I'm always stunned, and no, I'm not stunned now actually. I just know that the 23 people in the room, we have so much knowledge about what documents and processes are available in the system that I can pretty much guarantee that when I take this document to my statewide mental health services executive meeting, that no one else would have heard of it there, because they're so focused on delivering, that we are actually the consumer carer movement leaders that you all are. You have the knowledge of documents like this, and that is just so valuable. That and you'll find when you take this document to people, I would be surprised if people knew about it yet, because that's our role, to take it to them. So we play a critical role in that knowledge, as Hayley said. Thank you.
Thanks, Darren. Absolutely. I think you speak there so powerfully to the role that we all have in playing a leadership role in bringing this forward. You know, one of the most important things about consumer empowerment is self-agency and stepping in, taking power. It's not often given away. So it's very, very much up to us to lead the way. Thanks for that, Darren. Good reminder to finish off the session. Okay.
Thank you, everybody. Sorry, Kerry, didn't mean to interrupt. Thank you. We are recording this webinar, so we will make it available. I'm not sure how, whether it's going to go on the website, but we will make it available for others. A big thank you to Kerry and to our panelists. It was a fantastic conversation, and I'm really grateful for your time and for the generosity that you've shown here this morning. Thank you, everybody. I'm getting seeing lots of thank yous in the chat. It's been a great session, and look forward to speaking with you again. Bye-bye.
Bye, everybody. Thank you.